Okay. And can you just check if it's on LGS? Then I'm
Yes.
good to go.
See, a lot of participants are saying audio is not clear.
Okay. So maybe I'll try to use my headset. Better now?
Yeah, I think so. Say something.
Yeah. So I'm all ready to start.
Fantastic.
Okay, great. I'm so sorry. I forgot to put on my headset. And no audio, no audio. All right. Am I on LGS?
Can someone give me a heads up on that?
Yes, sir. You are on LGS.
Awesome. So I'm just starting my presentation. I just need one confirmation that my slides are moving. Ankit, you can do that. Okay. So
Please.
can you see that?
Yes. Perfect.
Perfect. All right. Good morning, everybody. Once again, I'm very happy to be back with you. And today we are dealing with a very, very interesting subject, which is the fight for space, which all of us go through. So this fight for space is something all of us in India are familiar with. And as surgeons, when we see patients like this, where a massive incisional hernia is threatening to rupture, then you are looking at a loss of domain. But then think of a definition. How do you define a loss of domain? When would you know this, that your patient has a loss of domain? First is, and this is something not too many people are aware of, it is an irreducible hernia. If that hernia is a large one, but still goes back inside, it is not a loss of domain. Okay? You would need an AWR procedure to fix the patient's problem. Otherwise, you're going to have raised intra-abdominal pressure, hypertension, intra-abdominal hypertension, and complications from there. So how do hernias become so big, gigantic hernias, which are shocking even to experienced surgeons? One of the things is the attitude of most general surgeons for smaller hernias tends to be, oh, it's just a hernia. I can fix it, not a problem. And you don't want to do something which is very big. So you kind of think in terms of doing the smallest possible operation, because you as a surgeon tend to think, let's not overdo things. Let's not do an elaborate operation when something very simple can work. So that simple could range from a suture repair to a small onlay patch or a small intraperitoneal patch or whatever. Another important and common cause is because your patient manages to convince you that the cost issues are so important that you feel like using either no mesh or a cheaper mesh or a smaller mesh. So if you're doing an IPOM, the expense is significant. So the surgeon tries to curtail the cost by taking a smaller sized mesh and maybe uses less fixation. It should vary in different individuals in different situations, but I'm pretty sure many of you would understand that this is a reality. Now, you have all known that Botox and PPP are off-label and new ways of handling loss of domain hernias, correct? This is something everybody is kind of aware today. But actually, in Argentina, way back in 1940, this actually came in a publication by Goni Moreno, who actually in 1940, he published that in gigantic hernias, they were injecting oxygen inside the peritoneal cavity. And this was the first time they did it. Okay, so PPP is not new. 1940 is when it started. Okay. Now, what should be the surgeon's perspective and game plan in the current times? First thing is you have to assess your patient. Okay, we are talking about a loss of domain hernia. You get the patient, assess the patient, then you optimize the patient, and only then do you operate. And this entire process can take as much as 3 to 6 months. Yes, it can take 3 to 6 months. Why, you ask me? Maybe the patient is obese. And in order to reduce weight, you need to give that patient 6 months realistic time for weight loss. I'm just giving you one example. Okay, so Ankit, you need to look at the participants and admit them, please, so that I don't get distracted by notifications. Thanks.
I'm on it.
All right, thanks. So now, what are you going to assess? The most important thing is frailty. So frailty would be a separate talk on its own. You know, this is a very, very important consideration. How old is the patient? How many comorbidities does the patient have? Whether the patient has a physical ability to walk, does she need help going to the toilet and cleaning herself up? Is she easily out of breath? What do the anesthesia guys say? Is this an ASA 3-4 or an ASA 2? So all these things together would come into frailty assessment. And the next thing that you need to assess the case is with CT scan. So CT volumetry is something which is very, very fashionable today. And what you see on CT is basically you see the defect and whether it's one or more than one. You look at the abdominal cavity volume, you look at the volume of the hernia sac, and you also note the thickness of each individual muscle. So these are the things you check on CT. Apart from this, there's one more thing you should check on CT is the status of the internal organs. For example, if the patient has gallstones or the patient has a colon cancer which has recurred after a previous colectomy, then you would need to look at all those things before you think in terms of an AWR. Now, this is an ellipsoid, and the abdominal cavity is considered to be an ellipsoid. The volume of the abdominal cavity is calculated on the basis of the ellipsoid formula. So it is the 3 dimensions A, B, and C into 0.52. So that is essentially how the CT would help us assess the volume. I'm sorry, something went into my eye. Yeah, so in this particular case, you can see now the hernia sac volume is being estimated in 3 different directions, and they are multiplied together. And the factor of 0.52 is included in it. So you get a hernia sac volume. So the volume ratio becomes the hernia sac volume by the abdominal cavity volume. So this is what Tanaka came up with, and this is commonly followed in many parts of the world. Okay, so this is essentially what we are looking at. This is a representation of the Tanaka's index. Okay, there's also another index, the sub-bug index, but we're not going there. So the definition, therefore, of a loss of domain hernia is that it is a large irreducible hernia which has a Tanaka index more than 25%. People tend to fixate only on the CT volumes and don't realize that the hernia is reducible. So just get your mind out of that single point of fixation. It's not just about CT volumetry, but CT volumetry is important. So after assessing, we optimize the patient. Now, what are the challenges of these patients? Why do they need optimization? And remember, my optimization is a complete separate talk, which I'll give sometime later this week. Okay. One, as I said, is the patients are frail. They have multiple comorbidities, including renal failure or stented, low ejection fraction kind of heart. They may have chronic liver disease, many other comorbidities. Closure issues, maybe there's a previous mesh, there's a huge amount of retraction, this defect is very wide, the muscles on the side are very thick and fibrosed, so you're going to have closure issues. You're going to have to think of abdominal compartment syndrome. So these things are all going to be there before you think in terms of a recurrence, and you should know that in a systematic review, the recurrence rate for giant incisional hernias can be as high as 50%. And many of these patients didn't become bad surgical cases without a history. So they may have had leaks, resections, ileostomies, multiple surgeries, disasters. So that abdomen may well be very hostile. So what are the principle-based strategies in loss of domain? Understand the principles first, okay? One is you can reduce the contents, the volume of the contents inside the hernia cavity, okay? So say, for example, you remove all the bowel, you remove all the omentum, or you do a right colectomy or a subtotal colectomy, you would reduce the content of the hernia sac, right? I'm not saying that these are recommendations, please don't misunderstand me, but these are the principles that people have attempted all these things. So what is the principle of these attempts? It is to reduce the content so that when you put back whatever else is inside, then you have less content crowding, less overcrowding. Okay, so you can also increase the cavity space. Now, this is a very, very important consideration today. When you're trying to put in all the contents back in surgery, your abdominal cavity has no space. So how can you increase the cavity space? You can increase it with PPP, also known as the Goni-Moreno protocol. So this is something you have to do in the OR. If you're planning to use a laparoscope under local anesthesia, make a small 5mm incision. We are showing an optical entry under local anesthesia and sedation. We're just eyeballing the hernia, and very quickly we take the scope out and pass in a Ryle's tube. Okay, we pass in a Ryle's tube and take the cannula out, and then on table we inject around 1400 ml of room air, and these patients must be given DVT prophylaxis and vigorous chest physiotherapy. Okay, and the patient is discharged, and the PPP works by stretching the abdominal wall and increasing the strength of the diaphragm. Okay, now you have complications. PPP is not a benign procedure. You can have deaths from PPP. Please do not underestimate the importance of PPP. And you can do this in the CT room. You can just use a needle catheter system under CT guidance. So you don't need to bring the patient to the theater. And that is also a very good way of doing PPP. Okay, so after this concept of increasing the abdominal cavity volume, what else can you do? You can increase the compliance of the abdominal wall. So the abdominal wall typically is, because of the long-standing hernia, the flank muscles are thickened, fibrosed, and not compliant, which means they won't stretch. So you can increase the compliance of the abdominal wall so that they can stretch once you put in all the contents back. So how do you do that? You do that by injecting Botox, which is botulinum toxin, and you do that before the PPP. Now, you might wonder why I spoke of PPP first, because PPP was historically the first thing that came in 1940. Botox is something which has come in the last few years. So what is Botox? Botox is basically botulinum toxin type A, and this is used by plastic surgeons, aestheticians, and we are also joining that group. Okay, so Botox works on the neuromuscular junction, and it inhibits the acetylcholinesterase, and the neuromuscular transmission gets blocked. All right, so the muscle becomes kind of paralyzed. So who needs Botox? In which patient groups should we give Botox? Now, any patient with a hernia defect more than 10 centimeter may be considered. I'm not saying give it, but those who do give it as a matter of practice, reserve it for patients whose defects are more than 10 centimeter. Why? Because these are the patients who would need an AWR procedure. And the argument is that if you inject Botox, then the muscles become lax and the abdominal wall becomes compliant. So you can actually just do a Reeve Stopa operation, and you don't need to do a TAR or an ACST in these patients. So you can avoid dividing the abdominal wall muscles if you inject Botox. That is the argument of those who use this regularly. Loss of domain is by far the #1 indication for Botox. Other cases, a giant inguinoscrotal hernia, where the same loss of domain phenomenon is going to happen. So you need Botox there. And as I said, if you're very particular, you want to avoid a component separation, maybe an obese patient, then you can inject Botox. Okay. Open abdomen. Disaster has happened. The patient's abdomen is open. The patient is now getting better, and you need to close the abdomen. How can you close it? Because it's already fixed laterally. It's a big defect. So you can inject Botox, wait for 7 days, and then close the abdomen. This is described. I think the Mayo Clinic has been doing some work on this. Also, giant Morgagni hernias or paraesophageal hernias may be considered for Botox. Now, the question is, how are you going to do this? How do you use this Botox? Okay, this is kind of like a very simple manual. I'm making it so simple that it cannot be any simpler. So please pay attention if you're interested in this. So you use 300 units and take 150 milliliters of normal saline. Okay, so you have 150 ml of the powder in the liquid. So keep 75 for the left side, 75 ml for the right side. So this is now reconstituted. Now you're going to inject 3 spots per side. Okay, so 75 per side, that means 25 ml per spot you're going to inject, which means when there are 3 muscles on the flank in one spot, external oblique, internal oblique, transversus, you're going to inject all the 3 muscles every spot that you're injecting, right? So it means that on average, you will inject 8 milliliter per muscle per spot. Okay. Now, how much of Botox is needed? Classically, 300 units is needed. Okay. You can use 200 in specific instances. People have described results, good results with 200 units, but 100 units, I think, is too little, and it is better not to use it at all. And we base all this practice on published papers. There are now multiple papers which have been published from South America, Spain, Australia, etc. Okay. So how Botox works is it reduces the defect diameter. The lateral pull of the flank muscles is reduced, so the defect diameter shrinks. Okay. The abdominal volume increases, and the closure rate improves because you have used Botox. Now, this is a small video of Botox infiltration, and you can just see what happens. It's just a 90-second video, so just pay attention. You need syringes and needles and 300 units. So remember, you're doing this in the ultrasound room. You're not doing it in the operating room. So you mark the bony landmarks and divide that flank into 3 parts, and those are the areas where you're going to inject. Okay. Obviously, if you have a large lateral hernia there, you're not going to be able to inject there. So as described, we are diluting or rather dissolving 300 units in 150 ml, and under ultrasound guidance, this you need a probe between 10 and 13 megahertz. So that way you can see the 3 flank muscles, and you can see the needle going in layer by layer. So inject into the internal oblique, the transversus, and the external oblique. Okay. So the results are now demonstrated here, where you have a pre-Botox size, a defect size, which has now shrunk by around 2.5 centimeters. And you can see that the muscle wall, each muscle layer has also become thinner and more pliable. Okay. So this you can definitely check when you do these cases. You just need to follow up the patient before the surgery and document that the drug has actually worked. Now, if the patient has very severe COPD, please don't use Botox, and probably you should reconsider your approach in that given patient. So does Botox really work? Here is a case. This is a young man who had a road traffic accident and grade 4-5 liver injury, and he ended up with 6 laparotomies for that liver injury, abscesses, re-explorations, and ultimately had a laparostoma which was closed with a skin graft. Now he has a 23 centimeter wide defect, and this patient, after 1 month of Botox, see this clinically, we are just pulling the rectus across to the midline. So it's so easily it is coming together. Okay? This is just an anecdotal case, but we have many such anecdotes. Okay, my practice in loss of domain hernias is that I would first get a good solid assessment of the patient with CT scan. I'll get the anesthesia people, the pulmonologist, the cardiologist, the diabetologist, all of them involved. And then I'll give Botox. And in the meanwhile, I'll start working on the nutrition and also on diabetes control and whatever else, improvement of the COPD status, all of that starts. Now, I will do this for 4 weeks, and the respiratory physiotherapy will be a key element for me. I'm very, very focused on driving the patient hard, on working hard for the respiratory physiotherapy. Many patients say, oh, I feel so tired, I can't do it, I can't do it. So you get after them. Just telling them to do physiotherapy doesn't work. You need to ensure they're actually doing what you expect them to do. So you give the PPP, you start the PPP 2 weeks after the Botox. The first day you give 1400 ml of room air, and every day you give 700 to 1000 ml for 2 to 4 weeks. And remember that PPP is not entirely benign. It may have complications, it may have fatalities, including pulmonary embolism. Once your Botox PPP is done, repeat your CT and check your results. Now, I will go into the operative highlights of the procedure, and we have discussed some of it when we discussed the open TAR technique, and those basic points are just revised. I will not hang on too long on this. These are your mesh requirements, and you need to have the sutures. The most important things are, the basics are, you enter through the safe zone of the abdomen, don't injure bowel, and you now document that your space is lacking. Now look at that abdominal cavity. There's hardly any space. So a 30 centimeter wide defect is what you're dealing with, and there is no abdominal cavity space. You can imagine the surgical issue here. Okay. So basically, you start doing the retrorectus dissection. This is the PRS in the subxiphoid area. This is the frenulum sign, which I spoke about yesterday. And that's a subxiphoid fat. This is the cave of Retzius and the pubic arch. This is the linea semilunaris with the lamppost sign. Now we do the TAR around a centimeter or two medial to the entry of the neurovascular bundles. Now, lateral dissection continues under the transversus, goes on to the fat over the kidney all the way till the psoas major muscle on either side. Okay. Now, I'll show you the neglected and important part of the diaphragmatic dissection. Many people do bilateral TARs, but are unable to close because of some factors. And this is one of those factors, that the area is a little scary and a little obscure. So they don't dissect cephalad. They go all the way to the sides, to the psoas major, and they go into the pelvis. That part is all fine, but they don't go cephalad. So that part, you don't get a release, and it becomes an issue for closure. So now you can see that this is the rib cage, and we have gone underneath the rib cage, and we are dividing the attachment between the diaphragm and the peritoneal sac. Okay. Now here you do not get typically well-defined fascia transversalis. So if you go a little away from the muscle, chances are you're going to make a hole in the peritoneum. So be careful. For the same reason, if you try to do a blunt dissection here, many a times that peritoneum will tear, and it will be very difficult to close that gap because it's further inside. So you can see that the assistant is pulling very hard on the costal margin. It hurts postoperatively. And when he pulls hard, then you can get underneath the diaphragm. And you keep going all the way till the central tendon. Okay. So this is the subdiaphragmatic dissection continuing. I'm dwelling on this for a little bit because I have the luxury of time, and you can see the steps of the operation using different techniques. You could use a peanut, you could use a diathermy, which is the usual instrument, and some of it you can use sharp, long scissors. Okay, now there is another view, another case, and now this is a spectacular overhead view, and you can see that's the diaphragm, and this is of course fast forwarded. And now we are doing the TAR mobilization, subdiaphragmatic dissection, all the way till the central tendon. You can see that heart is pulsating over there, and that really is where you need to go. Unless you dissect up to the central tendon, your TAR is incomplete. Okay, and that is one of the secrets of successful TAR. Another important part of the operation in a loss of domain case is the preservation of the sac. Okay, now this has to be well planned, because you can't just do the whole operation and then at the end you decide that, okay, I will need sac because my peritoneum is not going to get closed otherwise. So you have to plan for it beforehand and start mobilizing the sac from the skin flaps, okay, and harvest it. Now, when you harvest it, it can stay on the peritoneal side, it can stay on the anterior rectus side. So you want peritoneal closure. So on one side, for sure, you divide the anterior sheath edge of the sac. So what happens is the sac is now connected only to the peritoneum. So this is what I am showing in this clip. You can see that peritoneal flap. You can see the rectus muscle and the anterior rectus sheath are superficial. Now, when you do that, you can have a large flap of peritoneum which can bridge that gap after you finish your TAR. So this is one such case where you can see that peritoneal suture line is done, and at the center we have a small vicryl mesh. Then you place the mesh coast to coast, and this is, I've shown you this video before, it's a gigantic 50 into 50 mesh. This is Miguel Garcia Urania. so that is showing that it goes all the way from the central tendon to the pelvic floor and from one psoas to the other. Now, the question after you've done all this is, can we close this defect? Now, this is so obviously this is yet another loss of domain hernia. You can see that it's a 25 centimeter defect. Now, should we close it is an important question. Physically, you may be able to close it, okay? But should we close it or not? Because your patient may be very frail. Now, this is a very, very important concept. You must check the airway plateau pressures, okay? So if you tell your anesthetist, this is what you're looking at. Before closure, your plateau pressure is 17, say, and after closure, your plateau pressure should not be more than 6. So this delta plateau pressure should be 6 or below. If it is more than that, you need ventilatory support. If it is less, then you may do without ventilatory support. So now you're closing the defect because you know that the delta P is okay. You just pulled the abdominal wall edges together and hold it for the delta P to show. Okay. So this is the interrupted figure of 8 closure that I spoke about in the other day. And this is a peritoneal bridge, a peritoneal flap, where, you know, if it's a very frail patient and it's a very big defect, you're not getting together the anterior sheath without causing too much of pressure, then you can just take this peritoneal flap, which is on the external oblique side, which is the anterior rectus sheath side, and you flip it over and cover it so that you protect the mesh from the skin. Okay, then you trim the skin flaps, and then you're ready to close the soft tissue and skin. So this is the final part of the operation. Right. Post-op, do you need ventilation? I would say an elective ventilation overnight till the next morning is a very safe thing to do, but your absolute indication is when the plateau pressure is 6 millimeters or more. You must keep the patient in ICU. Remember, we are discussing loss of domain. We are not discussing a regular AWR case. You must be ready for a re-exploration, okay? And if you re-explore and find something like this, this is an unmitigated disaster, okay? Now, this is abdominal compartment syndrome. Now, the normal intra-abdominal pressure is 8 to 12 millimeters of mercury, right? Everybody knows this. The definition of intra-abdominal hypertension is when the intra-abdominal pressure is over 12 millimeters of mercury. And when it is above 20, you're actually looking at abdominal compartment syndrome. What happens in abdominal compartment syndrome is that the perfusion of the vital organs inside the abdominal cavity is impaired. The abdominal perfusion pressure is basically the mean arterial blood pressure minus the intra-abdominal pressure, because the intra-abdominal pressure is resisting the arterial blood pressure, right? So whatever is the difference is the pressure at which the organs get perfused. If the pressure is more than 60, then you can still salvage the patient, other things being normal, okay? Now, the most important thing to understand is that when the intra-abdominal pressure rises, there is compression on the renal vein and the IVC, leading to oliguria and hypotension, which can be fatal if you do not correct it immediately. So the ICU people tend to correct oliguria and hypotension with just more inotropes. That is a very, very dangerous practice, because inotropes will increase the splanchnic vasoconstriction and lead to the kind of picture that you're seeing here, which is a global mesenteric ischemia, and this is uniformly fatal. So you have to ensure that the patient does not have oliguria and hypotension for more than a bare few minutes. Now, this is a paper I would recommend you to read. This is from the Cleveland group, rather, and they talk about the concepts which I've already discussed of intra-abdominal pressure and handling the intra-abdominal pressure. Can you do an anterior component separation? Yes, you can do it. And this is basically a way of getting the midline closed, right? I would very much recommend that you read this article by Bisgard, which is a qualitative review on the surgical results of giant hernias. And the results are surprisingly bad with conventional methods. This is a 2014 article, okay? The Henniford group has published their 12 years of practice in AWR, and this is also a very, very illuminating paper. And recent 2019 World Journal paper on the definition of loss of domain. This is kind of an expert consensus group, which includes Henniford. They came in and gave a definition of loss of domain, which I've already shared with you. And if you read that article, you can read my commentary on the same subject, and I show my perspective on the definition. Okay. Now, this is how people manage the lack of space and the overcrowding. So this is how you struggle and somehow push all the contents inside and close the wall. Okay. Now, regardless of how you handle your LOD case, I have some submissions. There are some important issues to consider. One is that this is a tertiary care case. This is not a case to be done in a place with limited setup, with limited skill, or with limited experience. You may be very skilled, but if you don't have the experience, don't do it. You may be very skilled and experienced, but if your setup is not good, don't do it. Refer out. This is as good a case as one can get to refer out. And believe me, your life will be much better if you refer out, if you don't have these cases as part of your normal practice. The mortality rate in the best of centers would be around 5%. So you'll have to think whether your mortality rate can be as low as this, or it could be higher. Okay. This is a very expensive situation to have a patient treated with Botox, PPP, rehab, then post-operative ICU care, prolonged surgery. All of this is a costly affair. So please think that cost should not be a factor when you're handling a case like this. And I said that your infrastructure has to be really top class in order to handle a patient, because whether your patient deserves a closed midline or not, your patient deserves the best infrastructure and the best support that you can give. So this is typically how we handle and give results to our loss of domain patients. And most of these patients give extremely gratifying results, and all the struggle, the heartburn, the lost sleep, all of this, and the body ache, all of this is mitigated when you get good results on very high risk patients. Okay. And I'm very happy to help any of you who thinks there is a case that you need support for. And we are all part of a community, whether we are in LGS or in the AWR Surgeons Group, we are all together. And I'm once again delighted to be sharing whatever little I know and can share with you. Thanks for being with me. Okay. So that's it. I'll stop share. And I trust that.
Okay, let me thank you, Dr. Ramana, for another wonderful lecture. The slides are excellent. and the concept is so very clear. And thanks for the time.
Okay, so any questions? And Ankit, you can handle this now. If there is anything, you can. Yes, Mukund.
Yeah, so this is like, as you said initially, towards the end, dealing with the sac of the hernia when you want to plan. So that has to be done initially, as you said, that when you are entering into the abdomen. So what is the right place where to divide that hernia sac, leaving half off on either side, or
Yes.
you can leave the whole sac onto one side?
You would typically need to do adhesiolysis. So that sac is full of content. So you would typically go through the middle. One second. Ankit, that's not happening. Yeah. Mukund, I think you're okay now.
Yeah.
Mukund, you had anything else to say? Because we couldn't hear you.
Yeah, this is what I'm saying is there any way by which we can prevent half of the sac for the anterior closure and half for the posterior closure?
Yes, that is what I showed in the last part of that clip. You can do that. If you think that the midline may not be closed, you can use half of it for the peritoneal flap. So that is the peritoneal flap technique.
Thank you.
Yeah. Okay, so if anyone has a question, you can raise your hand and maybe the camera will pick it up. The software will pick it up.
People are posting it. Can you see it?
I can see it.
Sir,
there's a question about, can we do a laparostomy and leave it if plate 2 pressure is greater than 6? No, we are talking about a definitive planned operation for a loss of domain hernia. If you cannot close it, you can bridge it, use mesh and close it. But you may not be able to close the midline. That is all right. You are then doing a bridged repair, but definitely close the skin and put a mesh. Unless you've got into trouble like you've violated colon, you had a colonic leak, or now that's a disaster. But if you haven't had something like this, then put a mesh, definitely.
Then mesh should be covered with peritoneal flap.
If you have it, yes. So that is why I say it is important to keep the sac. One side, you divide the sac off the edge of the anterior sheath so that it stays with the peritoneum. The other side you keep. When the whole operation is done and you're now ready to close the peritoneum, then you use this peritoneal flap and see that you're able to cover the entire peritoneal sac. If you think that no, there is still a need for more peritoneum, then you use the other side peritoneal flap and again do the same thing. So you divide it off the edge of the anterior rectus sheath so that it is connected to the peritoneum of the other side. So now you have two peritoneal flaps which will close your peritoneal cavity for good. Then you don't have any more peritoneum, any more sac to bridge the midline. So you will have to close the midline. And if you cannot, then you don't have a flap to cover the mesh with. The mesh then becomes exposed to the subcutaneous tissue.
Thank you.
Yeah. If patient came with obstruction, where planning and all that is not possible, what can you do? So TAR is, or for that matter, ACST is hardly ever an emergency operation. So if you're dealing with obstruction and strangulation, deal with it and just close the skin, either close the midline anatomically or just do a simple repair or just close the skin. Plan your TAR later. There's no hurry. PPP starts after 7 days of Botox and continues for how many days? PPP starts around typically 2 weeks after Botox and you continue it for 2 weeks. So you get a total of 1 month minimum after you give the Botox. And that time is typically needed also to work on the respiratory reserves of the patient. I mean, I give more importance to this than to PPP. All right. Now, I must say this, okay? Many experts completely dismiss the philosophy of PPP and Botox. People like Rosen, people like Urinovitsky, Eric Polai, they do not use it. Rosen is scornful. The Cleveland group is basically scornful of it. They say that this is not evidence-based, this is rubbish. We can do a closure in almost all our cases with good technique. So this is a very big disconnect between the rest of the world and a handful of top-level experts. So my point is, do not use PPP and Botox randomly just because you haven't trained well to do a good TAR or any other form of AWR. There is no replacement for surgical skill and technique, and those outcomes are going to be critical. Just because you're using Botox doesn't mean that you can bridge over, literally speaking, poor technique. Technique is going to be very, very important. So whether you use it or not, your technique is what is going to determine outcome. And of course, the preoperative preparation also. All right, so I don't see any more messages. And if it's okay, then I'll stop the, okay. Okay, so thank you very much and see you again with something else.